Hi, my name is Ximing Shen. I am from Keio University Graduate School of Media Design, and today I'm here to present you with our paper, which is called Dementia Eyes, Co-Design and Evaluation of a Dementia Education Augmented Reality Experience for Medical Workers. So, dementia is a world-known public health crisis. According to the World Health Organization, currently there are over 15 million patients with an increase of 10 million per year. Dementia is an umbrella term for many neurocognitive disease. It can be classified into cognitive symptoms and non-cognitive symptoms. So the cognitive symptoms include memory loss and difficulty in communications, difficulty in visual and spatial abilities, and also difficulty in problem-solving skills. While the non-cognitive symptoms, which we also call the behavioral and psychological symptoms of dementia, BPSD, includes depression, anxiety, agitation, hallucinations, and delusions, etc. So while the cognitive symptoms of dementia cannot be reversed, clinical evidence has shown that the non-cognitive symptoms of dementia can actually be alleviated by careful provision of care services. But when we look into the current dementia care system, we notice that there are actually many barriers to dementia care, such as the economic inequality, the increasing demand for a dementia-oriented care system that distinguished from the other caring homes, and also limited access to dementia-oriented specialists. And for these specialists, the education quality that they received is pivotal in the provision of high-quality care services to those patients. However, the dementia education also faces many challenges, such as the lack of knowledge in both formal and informal caregivers, the temporary staffing of caregivers, and whether or not those medical workers can efficiently apply those theoretical knowledge to practical settings. So meanwhile, technology is providing new opportunities to dementia education because they are more enjoyable and has less geographic restrictions. The mainstream formats of technology-enabled dementia education include online courses, interactive discussions, and also the combined hybrid methods. On the other hand, more novel experience like XR has been explored in assisting dementia education, such as using task-oriented nurse role-play VR game for those student nurses, or VR dementia simulator focused on the daily scenarios of people with dementia. However, there are many problems in applying these technical tools into the area of clinical dementia care and education settings. For example, the social acceptability of applying new technology, as well as the insufficient inclusion of those end users into the design and development process, as one of the recent review papers on technology to support dementia education pointed out. So, because so far very little is known about the design process of how those XR technology is used in dementia-related education, we raised these three research questions. What are the design considerations for XR-enabled dementia education? How do medical workers perceive XR-enabled dementia education, and how effective is a simulation of dementia stakeholders' lived experience in impacting its user, and what is its potential in dementia care? So our contributions in this paper is that we co-designed a dementia education layer experience with dementia care stakeholders. we gained empirical insights about the potential of using an XR-enabled system in clinical dementia education. And we also analyzed the relationship between novel experience and self-reflection in the setting of dementia education. So to explore those three questions we just mentioned, we conducted 3 different studies. Here I'm going to elaborate the study design a little bit. In study 1, we explored medical workers' perspectives on dementia care and XR technology. We recruited 5 former medical workers and also invited them to a series of activities, including interviews on dementia care experience, an XR device experience session, and also design workshops. And then based on the results in study 1, we developed the initial experience prototype in study 2. So because at this point, the 5 participants that we interviewed with did not have a strong preference between AR and VR, we decided to create the first experience prototype in both AR and VR. We then tested the prototypes with the same participants in study 1, and then based on their new feedbacks this time, we then revised the prototype to one AR application with design workshop scenarios combining the original AR and VR scenarios. And then in study 3, we tested the revised AR experience inside actual hospital settings. We used both qualitative and quantitative evaluations to understand the empathy, emotion, and self-reflections aroused by the AR experience. So to quickly summarize, in study 1, we explored medical workers' lived experience in dementia care and also XR. And then we also explore how they think these kind of novel technology can be implemented into dementia education in the clinical setting. And then in study 2, we connected these lived experience of medical workers to the computer graphic-based XR simulations, and also their lived experience with people with dementia too, and designed scenarios. And then in study 3, we understood that the lived experience-based AR experience can help to increase empathy effect and elicits self-reflections on care service provision. And the key takeaway messages for this paper includes that we found that short sessions that allow interactions with other participants, in our case, other nurses and medical workers, can those kind of short sessions which can sparkle in-depth discussions and also comprehensive understanding actually received positive feedbacks from the participants, and this showed the potential of using XR in supporting clinical dementia education. And then second, for implementing novel technologies in the area of professional education, we found that the balance between technology choices, the different learning effects of those technology choices, and also the practicability of implementing it should be taken into consideration. And then the last point, in our case, we actually used visual disability simulation in the setting of dementia education. However, disability simulation is usually problematic because it can bring its users discomfort feelings, and also it could actually distance the users away from the disabled group that it was supposed to be helping. And therefore, the use of disability simulation should be carefully managed by researchers. So thank you for listening. For more information, please go to check out my paper. Thank you.